Our final speaker of the day is Dr. David J. Weber, who has been on the faculty of the University of North Carolina at Chapel Hill since 1985, where he is currently the Charles Addison and Elizabeth Ann Sanders Distinguished Professor of Medicine, Pediatrics, and Epidemiology in the UNC School of Medicine and UNC Gillings School of Global Public Health. Dr. Weber serves as an Associate Chief Medical Officer and Medical Director of Infection Prevention for the UNC Medical Center. He serves as Medical Director of the UNC Program in Infection Control and Epidemiology, or SPICE. He is the Secretary of the Board of the Society for Healthcare Epidemiology of America and the Deputy Editor of Infection Control and Hospital Epidemiology. Dr. Weber received his Bachelor of Arts degree from Wesleyan University in 1973, his medical degree from the University of California, San Diego in 1977, a master's in public health from Harvard University in 1985, and completed his medicine residency and infectious disease fellowship at the Massachusetts General Hospital in 1985. He is board certified in internal medicine, infectious disease, critical care medicine, and preventative medicine. Dr. Weber has published more than 480 scientific papers in the peer-reviewed literature cited in PubMed, and more than 600 total papers and chapters. He has trained greater than 50 students with an MPH or a PhD in epidemiology. His research interests include the epidemiology of healthcare-associated infections, disinfection and sterilization, new and emerging infectious diseases, including novel influenza, SARS-CoV-2, MERS-CoV, Ebola, and Candida auris, response to biothreats, non-tuberculosis mycobacteria, control of drug-resistant pathogens, immunization practices, especially of healthcare personnel, zoonotic diseases, and the epidemiology of tuberculosis. Dr. Weber, we can see your slides, but we don't see the full screen slide. We see your slide show your side of things. There you go, perfect. But you are still on mute, Dr. Weber.
Thank you. Yes, thank you very much, the famous double mute. Thank you very much for what I'm sure has been a long day for all of you. And I appreciate this opportunity to talk to you about pandemics and the global response. As we mentioned in the Q&A session at noon, even though we've been in this pandemic for 2 years, everybody, including myself, has pandemic fatigue. It's not a question of if we see another pandemic, but only a question of when we see it. So let me start off with some of the definitions from emerging, re-emerging, or endemic. An emerging disease is a disease that's not occurred in humans before, like SARS-CoV-2, but that has occurred only in small numbers or isolated places, like Ebola was until the 2014 outbreak. Re-emerging, a disease that were once major problems globally and then declined dramatically, but again became public health problems for a significant proportion of the population. Zika, as it moved from the old world to new world, might be described that way. Endemic is a long-term problem, never significantly declining. I do think SARS-CoV-2 will decline, but it is now endemic. It's not going away like SARS-CoV-1. So here's just some of the history of pandemics going back to the Antonine Plague in roughly 165, 180, believed to be the smallpox and measles. And then we go to the plague of Justinian, which was felt to be Yersinia pestis in around 500. And then Black Death, as you all know, in the 13 to 47, 1351. Actually, cases lasted for decades, but about a quarter of Europe perished in that plague, 200 million people. And then the devastating plagues in the New World of smallpox brought from the Old World to the New World with tens of millions, leading to the fall of many empires, such as the Inca Empire. And then Black Plague raised its hands again in various places over the next several centuries. I think we'll dip down then to the Spanish flu, 1918, 1919. 40 to 50 million people perished, and we'll talk more about that. We get out to the HIV/AIDS pandemic, which is still present and still causing a tremendous burden on individuals and societies. And we work our way through SARS-CoV-1 with about 800 people, Ebola and MERS, the big outbreak of Ebola 2014 to 2016, and now COVID-19. So if we look at, and you can look here at the size of the different number of people dying, and you can see down there somewhere is COVID, but I'll show you more recent data. Again, pandemics over time, just in terms of the deaths from antiquity to the modern era. Of course, these are not adjusted for the populations at the current time, but these plagues have been not only large in terms of number of people ill, but very large in terms of deaths. And I like this slide better because it actually uses gravestones, which is more appropriate there. And as you'll see with SARS-CoV-2, the 1918 influenza pandemic actually substantially is reducing lifespans. HIV really the one that's ongoing with more than 30 million people. I'll also point out to you that some of these like MERS and Ebola and others, those organisms still exist. And of course, the last flu pandemic we had was 2009. Turned out not to be a very important impact in terms of deaths, but a large number of cases. But we have a flu pandemic about every 20 years, but they can be more frequent. So nothing prevents us from having an influenza pandemic in the near future. Well, this was this is an older paper, a Goldie oldie, but I really like this paper. Mary Wilson really summed this up. Again, you can see here almost 30 years ago about basic concepts in disease emergence. First of all, it's complex and it's dynamic. It is changing constantly. Most infections are not caused by generally new pathogens, as we saw with SARS-CoV-2 there, from pathogens jumping taxonomic lines. About 75% of recent outbreaks, large outbreaks and epidemics have been caused, and new emerging diseases are caused by organisms jumping taxonomic lines. Most of us in high school took biology, and we sort of started with viruses, and then we went to bacteria, and then we went to fungi, and we worked our way up the chain. But the concept of the microbe, which is really how those courses are taught, is both inadequate and incomplete. That is, you really have to look at so-called One Health, really view them in relation to human populations, animal populations, and the environment. Human activities are the most potent driving facts driving disease emergence. Social, economic, political, notice also she listed climactic. This is 30 years ago. Technologic and environmental factors shape disease patterns and influence emergence. We need a global perspective, conceptually and geographically, to deal with this, and this is one of the problems with our management of SARS-CoV-2, and was true 30 years ago and is still true today. The current global situation favors disease emergence. I just want to point out to you, this is just some data from 1970 to 2016, and it just lists a graph of all the outbreaks and epidemic events, and I just picked one of the WHO regions, Africa. But I just want to point out to you all the diseases that were occurring in outbreaks there. And again, I want you to remind you, and I'll remind you again later, we're all only a plane ride away from any of these diseases, but here you have yellow fever, schistosomiasis, polio in those days, but still in Asia now, plague, measles, dengue fever, Crimean Congo fever, Ebola, and others. So, and you can see the large number of outbreaks for all of those. So again, these outbreaks due to these zoonotic agents are relatively common, particularly in lesser developed parts of the world. Here is the most recent data I can really find that lists all the countries and visitors to the U.S. And it goes through 2019. You just saw some data that it's dropped substantially in the last 2 years, so I didn't show that data. But it does show you that, well, many of the people entering the U.S. In terms of coming from well-developed countries like UK and Japan with relatively low risks for exotic diseases, you can see here places like India, Brazil, China are all listed as well in the top 10, and for which these more exotic diseases are quite common. And you can see it, not surprising, people are arriving all over the world, from all over the world, all over the time, and the number continues to rise and will continue to rise. One of the things that makes controlling these new diseases, such as Ebola or Omicron, and I'll mention Omicron in just a moment, is the speed of which people travel. So if you go back to 1850, For those of you that remember Jules Verne's book a little later, 180 Days Around the World. Took about a year to go around the world in 1850, and there were about 100 million people. Now, of course, we zip around the world in 24 hours, and there's more than 6 billion people. And certainly in the pre-COVID days, and even now, you just have to sit at one of the fancy airline flight clubs, and you'll hear people saying things like, oh, you know, I was in Singapore just yesterday, back here for a few days, and I have my next business meeting next week in Brazil. So people are flying all over the world, all over the times. So, of course, I'll just mention Omicron. First case reported at the end of November 28th or so, but the case was really was from November 23rd. Cases in South Africa now have been described. Once they started looking back to November 8th, and obviously within just a few days of it being described, it's now found in more than 60 countries and more than 30 states. So again, travel restrictions will slow the spread maybe. They're not going to prevent it, and we live in a global environment. And this is just an example of this here for geographic distribution of emerging respiratory viruses here. And of course, I remember the 2009 flu pandemic didn't start far away. It started in northern Mexico. By the time we even realized we had a pandemic, it was already in California and a number of the southern states. So you can see here the different avian influenzas and MERS and variant diseases, just as they started all over the world, and they move over the world very quickly. So again, we need to think about prevention on a global scale, not put on blinders and just think about our country. Sources of exotic diseases, of course, the number one is travel. Animal exposure, zoonotic diseases, about 3/4 of the emerging diseases are zoonotic. We have exposures via travel, leisure pursuits, hunting, camping, fishing, occupations, pets, worries about biothreat agents, research, exposure via laboratory work or animal care, all of which can lead to exposures to exotic diseases. And so here we have our infections in humans or animals. People keep exotic pets. We had the outbreak about 20 years ago of monkeypox because people wanted to import giant Gambian rats. I don't know why. And in the wholesaler, they transmitted monkeypox, which come from rodents, by the way. Monkeys are infected and die like humans. Transmitted it to prairie dogs, again, why people want those as pets, and then we had an outbreak. Certainly, alterations in livestock management have called variant Jakob-Creutzfeldt disease, acquisition of new virulence traits. The bugs are always changing and developing more resistance. They adapt to new hosts, as we see with SARS-CoV-2, not only infecting humans, by the way, but many cat species and minks. They've been mink to human transmission, changes in land use, tourism, infected animals, translocation there, and then climate change, which may mean diseases we saw in more tropical areas will return to the temperate areas. So here in the bugs, they adapt, they mutate, they vary. You have emergence factors, vectors, and zoonotic hosts. A lot of factors affecting humans, which I mentioned, demographics, travel, behavior, infrastructure breakdown in much of the world, commerce and industry that lead to those vectors being exposed to humans, and then disease manifestations and outbreaks. We need to keep in mind that for SARS-CoV-2 all of the roughly 800 cases outside of some parts of China came from one person who went to the Metropole Hotel in Hong Kong, and a physician, by the way, and infected a number of other people who then spread this into a worldwide outbreak there. So again, it can only take necessarily one human being infected with a zoonotic disease to lead to an outbreak. One of the key things, of course, is increasing population, leading to more urbanization, increase of older individuals, more travel, resource depletion, conflicts, global warming, more poverty, malnutrition. All of these favor emerging and re-emerging infections, and so I would clearly propose we will see more of these in the future. Some of these, like rabies, despite being with us for thousands of years, really just have stayed in animals. We don't have really, although there have been cases of human-transmitted rabies, it isn't propagated that way. This is an older slide, and I talked about limited outbreaks. I would argue that really the outbreak in 2014 was really a long outbreak, but again, it has not continued to circulate in people. And then, of course, you have HIV, simian HIV, which became HIV in humans, which continues to circulate now in humans without needing to involve animals. So they can be through a phase, and certainly SARS-CoV-2, as with the other coronaviruses, almost certainly started in bats. Some have intermediary hosts like MERS, which are camels. Others like SARS-CoV-2, really, there aren't any intermediate hosts that are important at the present time. By the way, if people say, well, this really snuck up on us, this SARS-CoV-2, here's the WHO list of priority diseases from 2015, and right there in the middle, other highly pathogenic coronaviral diseases such as SARS. So it may have been surprising to some people that we had this pandemic from a coronavirus, but it certainly wasn't surprising to the scientists at WHO and CDC who developed these lists. Others, of course, include things such as Ebola, Lassa fever, MERS, Nipah and other related paraviral diseases, and others, and Zika, of course, which, as you know, is now endemic in the New World. And again, just a list of some selected emerging diseases and their impact. Legionnaires disease, which really turned out not to be new, but really was newly described in 1976 and really had existed for a long time. HIV, of course, with tens of millions of people infected, is a new disease. Variant Jakob-Creutzfeldt, due to the way we were feeding animals, has largely been eliminated now, as has SARS-CoV-1. I, by the way, personally took care of the eighth and last lab-confirmed case of SARS in the United States. The monkeypox outbreak we had in 2003 with somewhere around 40 cases there coming, as I mentioned, from importation of animals. And then the Ebola outbreak 2014, but no longer in that large outbreak. But there have been many outbreaks in Ebola, and we could see others in the future, and we have one actually happening now. How does the WHO look at this? They classify initial introduction of emergence, localized transmission, amplification, and then hopefully reduced transmission. And then the response, key response, are early detection, which, by the way, it's really usually by an astute observer, not by a surveillance system, containment efforts, control and mitigation, and elimination or eradication. Elimination is the absence of a disease in a local area, measles in the United States. Eradication means gone from all over the world, such as polio types 1 and 3, as well as smallpox. And they used this to give the response to 2009 influenza. What it did take into account, it was only based on transmissibility, but not virulence. And the outbreak in 2009, the strain was not more virulent than standard flu, so had a limited impact. What about considerations, how you should manage these emerging diseases and pandemic threats at your hospitals? What are the key issues for all of us in infectious disease and infection prevention? Well, key is finding the pathogen and describing the taxonometry. And that is really what we've done that much faster. It took more than a year to find the cause of HIV, for instance, a substantial months to find the cause of Legionnaires disease. But here we had the first isolates of SARS-CoV-2, and within literally a week we had sequenced it. Once you know the basic nature of the organism, we knew SARS-CoV-2 right away was an envelope virus and respiratory transmitted. We knew masks would work. We knew as an envelope virus, alcohol disinfection would work. So just by knowing where it falls into the taxonometry, we know a lot about it. Epidemiology, areas of endemicity, incubation period, critical transmission routes. If it's airborne, then we want masks. If it's more like Ebola, then we need full body suits. How infective it is, and the Delta variant is much more infective, similar to mumps. Duration of infectivity, how long we isolate people, and then the clinical signs and symptoms and impact, morbidity, mortality. And once we know the organism, then we can develop diagnostic methods, which first we have to identify it, and then a little later therapy, unless that already exists. So first, the key is the modes of transmission. Once we know something about the organism, touching, indirect contact through the environment, droplets are airborne, and there's no absolute clear distinction. But as soon as we knew that SARS-CoV-2 was aerosol transmitted, we knew that masks and physical distancing would work based on earlier experiences. We know it's not fecal oral transmitted, although you can find SARS-CoV-2 RNA in the feces, and that can be a way of tracking disease. And then we need to know issues about transmission outside, and are there other vectors like there are for Zika, because it's often vector control that allows us to control those types of diseases. The key here is the so-called RO, R-O, or sometimes spelled R-H-O, which is the reproductive number, meaning if I'm infected, how many people on average do I infect? And here the row you can see is 3. And if you have exponential growth, if everyone is susceptible, then you'll get an outbreak. If it's less than 1, even if it's highly communicable, like rabies, really, we're never going to have, unless the virus changes its basic nature, outbreaks of rabies among humans, because on average, less than 1 human by far is infected, although there have been rare cases of transmission from person to person. And then we can look at the different diseases. This is an older slide, and you can see here, SARS is listed as 2 to 4 in that range there, but Delta is in the 8 to 10 range, similar to mumps. The most contagious disease we have here is measles. Smallpox is in the similar range. And as the virus becomes more infectious, then you need to have higher and higher coverage for a vaccine to work. So actually, data showed back just around before the time of the Delta wave, 80% of the U.S. either had natural infection or vaccine-induced immunity, and we still had a Delta wave. And that's because SARS-CoV-2, particularly Delta, was more infectious, and vaccines and natural immunity didn't provide complete protection. So I think it's no longer possible, I'll say that again, we will never reach so-called community protection levels like we do with measles, meaning if you have an infected person in the center, all the people around them here are immune, so you don't get an outbreak, and people who are not immunized or can't take vaccine are relatively protected. For the foreseeable future, people who are not fully immunized and boosted likely will be at risk for getting SARS, coming into the hospital and dying. Then as we move on to our infection prevention and managing a pandemic, what's the environmental survival, germicide susceptibility, isolation for SARS-CoV-2, of course, airborne isolation. Protective equipment is masks and face shields. There are 2 very good, and I listened to the question just now about how much you need face shields. They're clearly important in healthcare. There are multiple studies and 2 meta-analyses that show that it provides additional protection. But what we don't know is, if you go into a room without a face shield, what's your risk after X number of minutes, and how much additional protection, except it does offer additional protection. Pre-exposure prophylaxis is now available for SARS-CoV-2 with long-acting antibodies. Post-exposure prophylaxis with monoclonal antibodies as well is now available. And of course, we have pre-exposure prophylaxis with vaccines for SARS-CoV-2. Very important to develop that. Biosafety levels, since it's a biosafety level 3 SARS-CoV-2, very hard to study because you need special labs, but we don't need any special waste disposal for it because it's an envelope virus. Keys to managing a pandemic then, a sensitive and specific, ideally rapid diagnostic test, particularly if they have common diseases that aren't particularly distinctive. So somebody coming into your ED, you really can't tell unless they have one of the more unusual findings, such as loss of sense and smell and taste. You can't separate it from RSV or influenza. Protecting our healthcare personnel, personal protective equipment, particularly during donning and doffing, is critical. Sufficient staffing, which has been a major problem here, remains one, but obviously appropriate stockpiles of things and managing shortages in a just-in-time world of delivery. If we look at prevention, then pre-exposure is the best, and you then get an abortive condition, and we now have 2. We have vaccines and we have monoclonal antibodies, very important there. And of course, that's how most of our vaccines don't actually prevent infection, but it's a race between your immunity and the virus replicating. And actually many people who have had fully vaccinated will shed virus, live virus, but they themselves won't become ill. And ideally, it's to manage the disease before you actually reach the threshold of having clinical disease. Secondary transmission is treating it. We certainly have therapies for SARS-CoV-2 like remdesivir, and then we move into tertiary treatment and longer-term chronicity. And we don't have specific therapies known to improve long hauler syndrome, although many people are at work for that. And so again, in terms of medical need, we look at epidemiology, target populations, disease burden. We require preclinical development, then clinical development, phase 1 small safety and immunogenicity trials, larger studies on vaccine to do dosing and continuation of phase 1, and then the large phase 3 efficacy trial to prove safety and efficacy. And we had trials for all of our vaccines, each on the order that are authorized or approved in the US of about 30,000 people. And then we need to keep going after that with post-licensure studies to, for instance, demonstrate, which has been done, the immunogenicity in pregnant women and safety in pregnant women and fetuses. So those continued studies need to be done there. As you can see here, the relative size of the outbreak depends largely on, assuming everyone is susceptible, then the increased infectivity, and the higher the infectivity, the larger, in general, the outbreak. And as I mentioned, I do want to talk about this term, herd protection, which is commonly used, but I don't like because, one, we're not cows, and then we're not immune. It's really community protection. So early in the pandemic, here are the people who were infected, all the blues, everybody was susceptible, and the result, in a closed, confined area, we had these huge outbreaks. Then we went to a phase, which was where we're still in. Many people are immunized and will remain healthy, particularly the boosted individuals, but we still get transmission circulating among the unvaccinated individuals. Ideally, we'll move to a situation like this, where all of us would be protected by boosters, and if we need to, developing boosters such as Omicron, and those that have chosen in blue to not be immunized or couldn't be immunized, the infected people won't lead to transmission like we have with mumps, measles, and rubella. I don't think we'll ever reach that because at least at the moment, we'll see what boosters do. We still have people who have natural infection. They develop disease, many of them when exposed to COVID, and fully vaccinated people, certainly with Omicron and other variants, many of them will also at least shed virus, even if they don't become very ill. So we're going to need, I think, much better vaccines, and dealing with vaccine hesitancies, you heard in one of the earlier talks today, very critical in order for us to really ever achieve true community protection. How do we approach, as infectious disease epidemiologists, dealing with new and emerging threats? Well, here's the chain of infection. We start with the infectious disease. We need to identify that. Then we need to understand the reservoirs. Some, like SARS-CoV-2 now, are only humans. Others might involve animals, like malaria or Ebola. We need to know how it leaves the body, how it's transmitted between people, the portal of entry, and of course, the susceptible host. So let's start there. First of all, we can immunize people or give them monoclonal antibodies for SARS-CoV-2 or other diseases and reduce the number of people in the susceptible host. In terms of the infectious agents, standard precautions, which is wearing gloves when touching anybody's secretion or excretion other than sweat, will largely protect healthcare workers. If there's any concerns about an airborne or droplet disease, then a simple mask there. Immunizations will reduce reservoirs there. Portals of exit, obviously clean water and safe drinking water for many of the diarrheal diseases there. Control of aerosols, masks, physical distancing there. I think there's a small role for improved ventilation in SARS-CoV-2. And again, immunizations to prevent and limit the susceptible hosts. So understanding the epidemiology leads to logically planning how we intervene. And again, here is the scheme that we just saw, and here are Ebola and SARS from a paper I did with a colleague at Mass General, Erica Shinoy, just describing all the key epidemiologic aspects in terms of its transmissibility, incubation period, case fatality rate. And then based on that, we can initially make logical conclusions what infection prevention methods work. But then very quickly, we know we actually did studies about proving that alcohol that SARS-CoV-2 can live on hands for minutes to hours, but literally 5 to 15 seconds of an alcohol waterless use will eliminate that from the hands. Similarly, on surfaces of disinfectants, almost any disinfectant, EPA-approved hospital disinfectant will kill it. And we already knew that PPE will largely protect you, particularly masks. The biggest risk for working in an Ebola unit is donning and doffing, particularly doffing and taking off your personal protective equipment in such a way you might contaminate yourself. So at my hospital, we do use monitors to be there and make sure people put on and take off their equipment appropriately. And then we have pre-exposure prophylaxis now with not only vaccine, but monoclonal antibodies. And monoclonal antibodies can be used and are FDA authorized for post-exposure prophylaxis. Well, the bad news about SARS-CoV-2, of course, is more than 5 million deaths, more than 260 million people infected all over the world. And if you look at the curve of cases there, what you would see is it remains essentially a linear increase. And so, well, in some areas of the United States, some areas of the world, there's been some control. We are not anywhere near, from a worldwide standpoint, the peak. We have no evidence that SARS-CoV-2 has peaked. What about the United States? I just updated the slide. Recently, 7-day averages, cases are up to about 120,000. Following the Delta peak, they dropped to about 40,000. In June, they were down to 10,000. So in the last 7 days, a 37% increase. Deaths are back over 1,000, up 28%. Hospitalizations up 16%. So we had the very large wave in January through March. Here was our very lowest point in June, and there was a lot of hope that we really had COVID under control. Here's the Delta wave, and we're back up. Unclear what's driving it, but undoubtedly Thanksgiving, more mixing, lack of mask mandates. Really, we'll wait to see what happens with Omicron. Here, by the way, is the U.S. Almost everywhere in the U.S. is in the high zone. There are a few spots that are moderate and just a couple that are low. And I thought you'd be interested in Delaware. And you can see here, Delaware remains all in the red zone. 7-day metrics, 4,000 cases, about a 10% positivity rate, and hospital admissions increasing as well. What about driving the cases, and what drove the Delta wave was the exponential increase in Delta, which is by far still the dominant variant, not only here in the United States, but worldwide, but very big concerns, particularly in Europe initially, that Omicron will overtake that. Delta with increased transmissibility, increased virulence, decreased protection from symptomatic infection by vaccines, but still good protection from severe disease. We talked about vaccine hesitancy and resistance, resumption of fall activities and holidays, public resistance to mitigation strategies, 3 studies all showing that a roughly 2 to 2.5-fold higher risk of hospitalization there. Omicron already, this is outdated, even though I made it up on Saturday. Now 60 countries reporting Omicron, more than 30 states. Escape from monoclonal antibodies, most monoclonal antibodies and natural immunity, and reduced coverage for fully vaccinated people. Well, I want to turn now to the conceptual framework for factors affecting a pandemic's trajectory. This was designed for COVID, and it was by a task force of the National Academy of Social Insurance, and I was on that working group. We can start with host vulnerabilities, which are key, congregate settings, lowest socioeconomic status for a variety of reasons. I will point out, while this disease has had a disproportional impact on Latinos and Black individuals, once they reach the hospital, they do just as well. So it's all access to medical care, having to work, not being able to stay home and work, more contact, less access to vaccines and other issues. Public health measures are clear. Some are individual, like wearing a mask and physical distancing. Others are secondary, like testing for early identification, contact tracing, and vaccines. Certainly viral factors, prevalence, transmission, mutation. Again, this was written long before the Delta wave was already realized that was important. Policy effects, all of those. Treatment, which we do have new cases. Direct effects, which are important, critical. Morbidity, mortality, a variety of indirect effects on the economy. School closures, very important. Non-COVID healthcare issues, decreased access to cancer care, for instance, and heart disease. Social inequities playing a large role. And you can see some of these are in the feedback effect. Short and long-term disability, 30% of people with COVID can have long-term issues, unemployment. Again, I just updated this slide. This is the overall impact of SARS-CoV-2 there. You can see here more people have died of SARS-CoV-2 than in all major wars going back decades. We've surpassed by far the people who died in the 1918 flu pandemic. Although I will report these are not adjusted for population sizes, and more people died per size of the U.S. in the 1918 flu so far than have died of COVID. But again, a frightening statistic, data from the University of Washington's projections that early next year we'll have surpassed 1 million deaths from COVID, and roughly 1 in 100 people over 65 has succumbed to COVID already. There, in terms of leading cause of death, this was the third leading cause of death, SARS-CoV-2 in 2020. Almost certainly will be the third leading cause of death this year. But in the months when we have peaks, like with Delta, it was the second leading cause of death, and in some weeks almost surpassed the heart disease. Again, keep in mind, putting in a comparison, about 100 people a day die in cars or from gun violence in the United States, of which more than half are due to suicide. Here's the impact of true death rate in the United States with the impact of the 1918 flu, and you can see the dramatic increase just due to that one pandemic and the crude rate of death. But here now look at more recent data here in the United States on the impact of life expectancy due to COVID, and you can see a drop in all groups and a substantial drop and a disproportional effect on Latinos and Black individuals, and this is because of increased risks of infection and pre-hospital issues, and not because of what happens once they reach the hospital. In terms of seroprevalence in the U.S., data from a blood bank study that covered 1.5 million people, 75% of the population was in those catchment areas. This came out in September, so really the data is before the Delta wave there. And at that point in time, 83% of people either had vaccine or had natural immunity, and we still had the Delta wave. So while a year ago, if I was talking to you, I would have said, I hope, looking at the infectivity of SARS-CoV-2 and vaccines, once we reach 70% immunity, we'll start seeing community protection. Here, despite having 83% of the population having some immunity, we still had that huge Delta wave spike, and it's not helping us now. And that's because in addition to the vaccine resistant, even natural immunity and fully vaccinated 2 doses, not boosted, we don't know yet, those people can have breakthrough disease, and people with natural immunity can become infected. So we're going to, in the long term, have to think about long-term strategies to protect the most vulnerable people in our society. I'm not going to go through this in detail, and you're free to get all the slides. Impact of coronavirus in households. Half of households in the 4 largest cities had serious financial problems. It was focused on Black and Latino individuals there, and often due to job loss or wage losses. 4 in 10 Black, Latino, Native Americans have used up all of their savings. Only 1 in 5 households report members unable to get medical care. So again, we've seen a diminution in cancer and heart disease care, either because people are afraid to come into the hospital getting COVID, or because we don't have the staff to take care of them because everyone's doing COVID care. More than 1 in 3 households with children face serious problems in education. Again, these are going to be long-term effects there. and 1 in 3 households in the U.S. lack broadband access, again, handicapping their education. Moving now to, again, the worldwide impact. GDPs are down worldwide, working force is down worldwide, extreme poverty is increasing there. This is here in terms of surgeries and other therapies and cancer patients lagging behind the need. So many long-term impacts in the U.S. and worldwide. You're all familiar with the disparities in the U.S. I've mentioned those before, but African Americans and Latinos have substantially higher case rates for SARS-CoV-2 and have had substantially more deaths for their size of the population. Again, that's not because of their level of care once they reach the hospital. This is all because of increased crowding, lack of access to personal protective equipment, needing to work in person, and various socioeconomic and health access issues. Vaccinations in the U.S. here, you can see we're not anywhere near our high point of 4 million, dipped down in June when the cases were low, have drifted up. Some of these bumps are due to, as we keep expanding lower childhood ages, and the latest bump likely due to a combination of people getting boosters and lowering some of the childhood ages as well. But as you can see here from the most recent data, when you look at people 5 years and above, we still have 40 here. There you can see a large percentage of the population has not received their vaccines there, and we have roughly 20% of the population totally vaccine hesitant. The number of people who are resistant, hesitant, has dropped dramatically over the last year, but that 20% who are really resistant has really not changed at all. We have had good impact of vaccines on older, good uptake in older individuals, and here we are, many countries ahead of us, including Chile and Cuba and Qatar and Cambodia, and here's the U.S. So when I looked at it this weekend, ranking 50th. What has vaccines done in the U.S. here? Risk of testing positive for COVID and risk of dying if you're by vaccine status, 6-fold higher if you're unvaccinated, and dying 14-fold higher if you're unvaccinated. We've saved over 90,000 deaths since June of 2021 by vaccines, and this will only go up. And as I said earlier, I see the world, the U.S. divided into 2 groups, fully vaccinated, boosted, and young children, and those who are unvaccinated, and most of the cases will be there. At my hospital, if you look at floor cases, ICU cases, and deaths, we're 85% unvaccinated, 95% unvaccinated, and 98% unvaccinated, respectively. And of those vaccinated in the hospital, 2/3 are highly immunocompromised. Again, if you look at data here and disparities in vaccine acceptance, look at the unlikely adopters. Here we are all the way back a year ago, all the way up through August 23rd, in that 15 to 20% range, no statistical difference. The number of people vaccinated, obviously increasing there. You can see the interested, that number decreasing as they then became vaccinated, and the cautious are going from 45% down to 8%. But we're somewhere in the 20 to 25% range of people who remain against getting vaccines, despite all the data on safety and efficacy there. And then lots of disparities there in terms of the unvaccinated people, in terms of population, education, income, and urban versus rural, as well as political leanings. Long COVID syndrome there depends on different definitions. Certainly, people who get COVID, most become ill. Many are asymptomatic. They may often feel ill for a few weeks after they're no longer infectious. And then, depending on the study, somewhere 4 to 12 weeks, you enter into chronic COVID or a long hauler phase. The acute infection leads to viral proliferation, cytokine storm, leading to organ damage, altered immune status. Comorbidities make that worse, particularly drug side effects. You can get secondary infections, inflammation. All of these can lead to prolonged symptoms and prolonged long COVID. Some of the long COVID symptoms, particularly in sick patients, are undoubtedly due just to being in the hospital and ventilated. But even patients who had very mild disease can often have long COVID. and that can be quite significant here. I'm not going to show you a lot of studies. Here was a very large EMR database, roughly 300,000 COVID survivors, 3 to 6 months afterwards there. Result there, 57% had one or more long COVID features during the whole 6-month period, 40% roughly between 3 and 6 months. 1 in 3 had more than one feature recorded there, significantly higher than for influenza. 2 in 5 patients who had long COVID patients had no record. So it's not just exacerbating underlying disease. These are new symptoms there. People, the sicker you are, the more comorbidities you have, and the older you are, the more likely you are to have suffered long COVID, which can affect virtually every organ system. Some of the particularly important ones are so-called brain fog, continued respiratory problems, fatigue, shortness of breath, chronic kidney disease, hair loss, as you've seen from many of the Hollywood stars. Well, let's turn now. We understand that transmission, COVID is an aerosol transmitted disease. If you wear a mask when you're ill, you largely protect people around you. If you wear a mask when you're not ill, you're largely protected. Being outside, a large airspace there, wind and other things, sunlight, all decrease COVID risk. So being outside is relatively safe. Time is important there. And the risk of disease is the joint probability of that. Risk is reduced by vaccine receipt, non-infected and infected people wearing masks, physical distancing, hand hygiene, and surface disinfection. Again, transmission, aerosols within 6 feet are most important. Disease greater than 6 feet has been shown, but generally with poor and directional airflow. Role of the contaminated environment is there, but it's minor. Pre-symptomatic and asymptomatic transmission are very important, obviously, since people don't know they're sick. So that's why universal mask wearing, like in schools, is important. And prevention in hospital adhere to universal pandemic precautions, that is wearing a mask, using eye protection at all times when you're dealing with patients, wear your mask 100% of the time. Here's a hierarchy of research designs from case reports all the way up to randomized clinical trials, cohort studies, and meta-analyses, and you're all familiar with that. So let's look at what mitigation strategies work for COVID. By the way, they work for all the other respiratory diseases, which is why, in general, in the last 2 years, we've seen very little disease. We did have a burst of RSV in the spring, but in general, we haven't seen those diseases. And in my hospital, we really don't worry about measles and chickenpox and TB because everybody's masked. So first, universal pandemic precautions, which I mentioned, COVID vaccines, physical distancing, PP monitors and buddies, monoclonal antibodies. All of these have been demonstrated to be particularly useful for COVID and will work for any highly communicable respiratory transmitted disease. We do the things we've always done for communicable diseases: good hand hygiene, contact tracing with isolation and quarantine as indicated, and wellness self-checks, although presenteeism remains a major problem at hospitals, people coming to work when they know they're ill. In my hospital, just in the last week, of our healthcare providers who had developed COVID, 30% worked for at least some time while they were ill. So how do we protect ourselves? I'd always called this the Swiss cheese model. I said others. These investigators prefer the Emmentaler cheese model. The way you get transmission is when all the holes line up, and you can protect yourself by physical distancing, hand hygiene, not touching your face or face, wearing your mask, vaccines, and others. And this is a general issue for when we see problems. So when car crashes occur, it's usually not any one thing. It's somebody driving too fast, in poor weather, alcohol impaired, not wearing their seatbelt, et cetera. So there are multiple ways of protecting ourselves, and when all the holes line up, then we get disease. And we can break down factors undermining prevention. And I really encourage you to read this paper, excellent. Misinformation, inequities, pandemic fatigue, vaccine hesitancy, those undermine prevention, favoring prevention, public trust, education, harm reduction, and effective risk communication, which we should be doing with all our patients. Here's the data at my hospital: 1,500 patients seen and only 2 possible healthcare associated cases, all thanks to appropriate personal protective equipment. Value of masks and hygiene. This is in the community, so just one of many studies, but I want to point out this study, cases and controls in Thailand, wearing a mask at all times during contact, independently associated with a lower risk. Their shortest distance, so if you stayed more than a meter away for less than 15 minutes, didn't share cigarettes, you often did hand washing, always wore your medical mask. All of those were independently predictive of a lower risk of acquisition of COVID there. So again, these are additive. The most important here is wearing a mask, but all of the others are important. Community transmission and within school transmission, again, just showing you, and I was a co-author of this paper. Here is what's happening in the community in black here. Primary cases out in the community are in red, secondary cases in blue. And what we showed is by universal mask wearing in the schools and practicing greater than 3 feet distance while eating and drinking, that for every 20 cases in the community, there was only 1 case acquired in the children acquiring cases in the community, only 1 acquired a case in the school. Also, you can see here that one of the risk factors in high schools was contact sports. So that's the one thing that's a problem. What about during the Delta variant? Again, here's Delta becoming exponentially larger starting in June. Here's acquisition outside of the school following with a little lag, exponential rise, and a little bump in school-acquired cases. But again, here during the Delta variant, again, 20 school districts there. You can see that wearing a mask, universal mask wearing in children, physical distancing when they're not wearing a mask is largely protective there. Again, for every community case, for every 15 roughly community cases, only 1 case in the school. So again, we know how to prevent transmission. We just have to be willing to do that. What are the strategies that don't have supportive evidence? Enhanced ventilation, there's really not any scientific studies. I'm not saying it doesn't work. I'm just saying there are no scientific studies that really demonstrate that it does work. There have been outbreaks on planes, 1 outbreak in schools where the teacher wasn't wearing a mask, had HEPA filters and open air, open windows. So that remains to be demonstrated. Routine testing of asymptomatic people might be useful if you do it very frequently in sports teams and universities. I will tell you that testing is not, I'll say it again, testing is not a mitigation strategy. It's an early identification and rapid strategy for isolation and quarantine. There's no evidence that plexiglass barriers prevent infection, and routine COVID testing prioritized generating procedures in hospitals. There really is no evidence that that's going to prevent transmission, nor is it necessary since we're all wearing appropriate PPE. And this is my really last slide. This is from a paper I did with David Henderson at NIH. Looking backward and forward, what did we do wrong? We didn't really have a well-coordinated federal response. Our public health infrastructure was inadequate, slow scale-up of testing, inaccurate initial assumptions about transmission, didn't have enough stockpiles of PPE, and we never rapidly ramped up production of PPE. There, we didn't initially recommend masking in the public, and initial failure to focus on transmission in nursing homes. Remaining problems are science denialism, politicalization of the pandemic response, vaccine hesitancy. We need to expand vaccines for children, which is being done. Evolution and spread of, this is several months ago we wrote this, spread of more highly transmissible and virulent pathogen variants, and that remains a problem. Post-COVID clinical issues will be with us for years to come. Lack of public support for public health interventions, which we're seeing thousands of public health workers have quit. Need for recurring boosters, we don't know. I'm sure we'll have unanticipated challenges, and we all suffer from pandemic fatigue. So SARS-CoV-2 is now endemic. We need a coordinated public health and political response to not only meet this pandemic, but prepare for the next one. Mitigation strategies have proven benefit, vaccines, universal pandemic precautions, physical distancing. All of the above are valuable in the community as well there. Other strategies like hand hygiene and contact tracing are appropriate, and mitigation strategies that have been recommended but for which we don't have evidence, routine testing of asymptomatic people and healthcare providers, plexiglass barriers, and improved ventilation have not been shown. There is, well, at least scientific evidence doesn't support their use at the present time. And so I'll end here. All of you are my heroes for all you've done during the last 2 years of the pandemic. You all deserve gold medals. You're all superstars, and we all thank you. So thank you very much, and I think we have a few minutes for some questions.
We do. Thank you so much, Dr. Weber. That was very informative. There is a question in the Q&A. What do we know regarding prior wild COVID infection and immunity? Are those individuals considered or not considered part of the group to lessen propagations? Discussions don't generally address this group other than to be considered unvaccinated.
So we do know there are 2 excellent CDC studies which have been looked at if you have natural infection to SARS-CoV-2. First of all, different SARS viruses don't cross-react very well and give you protection. So having had SARS-CoV-1 or MERS or one of the 4 endemic coronaviruses is not going to protect you against SARS-CoV-2. So let me start with that. If you've had infection with SARS-CoV-2, one study showed that you had about a 3-fold higher risk of getting disease than a fully vaccinated person. Another study from CDC showed about a 5.5-fold higher risk than a fully vaccinated person. Studies of giving vaccines to people with natural protection, meaning they had COVID, show a substantial boost in antibodies and a substantial protection against future infections. And that's why, both to give you better antibodies and longer-acting antibodies, it is recommended that anyone who's had SARS-CoV-2 should become immunized once you're out of the infectious period, which is 10 days for most people.
Thank you. Another question. Can you expand on your statement of the U.S. public health infrastructure is woefully inadequate?
Sure, absolutely. I'll give you a personal experience. Just in my county, we had a number, which is a relatively small county in North Carolina. We had an outbreak, a number of outbreaks early on in nursing homes. The small number of people in the county health department couldn't go out to help. We were sending people in the dozens from our hospital to help with outbreak control and provide therapies. And once monoclonal antibodies became available, doing that. Just in the last month, we had an outbreak at our county jail. Again, the 2 or 3 people in my county who were trained to do this from a county level couldn't manage that. We actually sent our healthcare workers to deal with that. Because of the politicalization of this, and many people, including myself, because I've recommended vaccine mandates, getting death threats, a number of people have left. And in much of the United States, the ability to do contact tracing, not only for SARS-CoV-2, but keep up their contact tracing for HIV, TB, and other key diseases is just not proved adequate. It's not because they're not well trained or they don't have interest, there just weren't physically enough of them to do the activity with SARS-CoV-2. And that's only gotten worse due to many leaving this because they're overworked, underpaid, underappreciated. And in some cases, they felt they had to do that because of physical threats of harm to them and their families. And people have shared emails with me that said things like, we know where you live and where your family lives, and we're coming to get you.
Yeah, that's frightening. What level of natural immunity combined with vaccinated individuals will get us to an R0 of less than 1?
So the answer is I don't know at the present time. There are not good data yet on there was data coming out of within a few weeks of booster shots in Israel that showed a 5 to 10-fold enhanced reduction of transmission to Delta. But longer-term data is not yet available. We don't have data yet for boosted people against Omicron. So what we really need to know is 3, 6 months after a booster, 12 months, will people who have been boosted actually not get infected and become infectious? And we don't know that. We do know that many people, if not most, who have had fully vaccinated against Delta still become ill, still have virals that can be isolated from their sputum, but they never become ill. They just become infected, I should say, and can transmit disease, at least based on the amount of virus. So it's not clear if we'll ever reach R naught less than 0. I'm not saying we won't. We just have to wait and hope that boosters will drive us over that. And 2, that the large numbers of vaccine-resistant people will accept vaccines, and we'll get up to levels like we have in society with measles vaccine, which requires 95% of the population to be immunized, and we have reached that, and we have eliminated measles from the United States, reaching those very high levels. But that is a big hurdle for COVID vaccines.
Well, thank you very much, Dr. Weber. That's it for our questions. And I think that's it for our conference as well.